Efficacy of the cardiac septal occluder in the treatment of post-bariatric surgery, leaks, and fistulas.
Welcome to the GIE Author Interview Series. I'm Dr. Christopher Thompson, Director of Endoscopy at Brigham and Women's Hospital. I'm here with Diogo Moura, who's our Advanced Fellow, and we're going to discuss our recent publication, Efficacy of the Cardiac Septal Occluder in the Treatment of Post-Bariatric Surgery, Leaks, and Fistula. Leaks and fistula are rare complications following bariatric surgery. However, as obesity is a pandemic and these surgeries are being performed with greater frequency, gastroenterologists are starting to encounter these complications more commonly. There are several different endoscopic techniques that may be used to address these complications. For acute leaks, it is common to use a fully covered esophageal stent to seal the leak, and that tends to be quite effective. For chronic walled-off fluid collections following a leak, double pigtail stents can be used to drain the fluid collections. However, there are still several leaks that aren't responsive to these techniques, and that's where this new device, the septal occluder, may be helpful. The septal occluder is a dumbbell-shaped stent made of nitinol and interwoven polyester, and it promotes tissue ingrowth and occlusion of the leaks. It was originally developed for interventional cardiology and to occlude septal defects. However, it is now finding a home in therapeutic endoscopy, and Dr. Moura is now going to tell you about our study.
Our study is a retrospective multicenter analysis including 90 centers from the US and South America. The inclusion criteria were patients with a leak or fistula diagnosed by clinical history and imaging examinations, such as CT with contrast or upper GI studies, including contrast swallow or upper GI endoscopy, who were treated with the cardiac septal defect occluder. The outcomes of our study were technical success, clinical success, and safety profile of the device in leaks and fistula post-bariatric surgery. Clinical success was defined as complete resolution of the external drainage with image documentation of closure after at least 2 months. All patients were seen in clinic before the procedure to discuss the risks, benefits, and alternatives to the off-label use of this device. For the analysis, leaks were grouped according to the International Sleeve Gastrectomy Expert Panel consensus. The device size was chosen according to the size of the defect, as per interventional cardiologist recommendations, with a diameter of at least 50% larger than the defect. Our results, including 43 patients with a mean age of 39 years, included 31 fistulas after sleeve gastrectomy and 12 fistulas post-Roux-en-Y gastric bypass. Of these fistulas, 38 were gastrocutaneous and 5 gastropulmonary. The majority of patients had failed conventional treatment. Technical success was achieved in all patients, and clinical success was achieved in 39 of 43 patients. All patients with chronic and late leaks had successful closure, with the exception of one late leak related to an undrained cavity. All 5 patients with early leaks initially had a good response. However, within 30 days, drainage recurred. In these cases, the cardiac septal defect occluder was removed and replaced for a larger diameter device, leading to permanent defect closure. All 3 acute leaks failed to the treatment with the cardiac septal defect occluder. Besides the initial success, after 72 hours, drainage reappeared. In all these cases, endoscopy showed enlargement of the defect and the device was removed. In these 3 cases, patients were treated with self-expandable metal stents. The mean follow-up of our study was 34 weeks. No adverse events and no deaths related to the use of the device were reported. We also performed an univariable regression analysis, which showed that chronicity and previous treatment were associated with successful fistula closure. Additionally, a multivariable logistic regression analysis showed that latent chronic leaks is a significant predictor of success, with an odds ratio of 3.99 compared to the acute and early leaks, after controlling for age, sex, and fistula size. In summary, this analysis found the cardiac septal defect occluder to have high efficacy rates in patients without acute leaks. All cases of early, late, and chronic leaks were successfully treated, except for one undrained late leak. However, early leaks required a second placement of a larger device in all cases. Our results suggest that the cardiac septal defect occluder should be considered for late and chronic fistula, and that traditional closure methods are likely preferred in acute and early settings.
So thank you for that nice overview. So as a result of this analysis, we do believe that the septal occluder device is useful as a secondary option when primary alternatives fail in these very complicated patients. And we hope you enjoy reading the manuscript.